have Dr. MOHIDEEN Abdul Kadir, Chief of Glaucoma Services at Aravind Eye Hospital, Tirunelveli. Sir will be talking about cataract surgery in angle closure disease. We all know which is very difficult to do a cataract surgery, and he will be talking on how to traverse the limited space.
So the tough case to do a cataract surgery in angle closure glaucoma. Just give a small example. A 67 years old female patient, 1/8 patient, came with acute attack in right eye. Axle is 21.47, lens thickness 3.61, and IOP is 46 and 0.1 cup. Other is 56 and GOA. And she had undergone a trabeculectomy for this disease, and after that she had a shallow chamber in day 1, pressure is 19, and it was around the day 15 is 50, and we all just managed with medical management, and we just waited for 4 months, and the vision dropped because of cataract. And so the post-trab AC shallow, speed grading is 2 to 3, and serial negative, and clear lens, and vision 160. Pressure now 10 with 2 antiglaucoma medications, and the loading dose of topical steroids and atropine. We are suspecting a malignant glaucoma along with cataract. So what do you want to do? We had a vitreoretinal surgeon standby for vitrectomy, and this is a video just to show. We just put 2.8. We put a Triptan blue, and we stained the anterior capsule. We released all the pus. We formed the anterior chamber. We removed this people stuck from the ostium. Then we use multiple side port. So you can see that pupillary membrane is one of the culprit which is not allowing the AC to form. So we just swept all the peripheral syna here from the pus. Then we found out the pupillary membrane. So we just remove the pupillary membrane. It's like a capsular rhexis called pupillorhexis. So we just remove the rhexis first off, do a 360-degree remove the pupil. So once you remove the pupil, you are more or less sometimes we think of the anterior capsule, so we have to be careful. So you don't puncture the anterior capsule. So once you remove this pupillary membrane, and then you get a clear idea about the anterior chamber. So once you get the so if you do a 360-degree pupillary membrane removal, then it'll be very easy. Then you can see, then you form the AC with high viscosity viscoelastic. Then you use a high-res hook. So no, don't hesitate to use high-res hook. So use a high-res hook. So normally we make 4, but here sometimes we can make even 5 also to make the pupil a little bigger. So once you form the AC, once you remove all the peripheral synae, then you remove the pupillary membrane, then more or less much easier. And see to that you give intraoperative mannitol also be given at least a 200 ml on the block room, one on the on table. So you make the eye a little softer. Then you do again you use of forceps, because this has a weak zonules, and this most of the lens will be anterior subluxated. So you have to be careful. So you cannot use a cystitome to complete your rhexis. So use you go back and retake that rhexis margin and complete your 360 rhexis. Then once you lose the rhexis, then you can't do a phaco, especially in these cases. So everything has to be precise, and you have to plan very well before the surgery. So as the experienced surgeon, is better to do this kind of cases, because sometimes very difficult to manage, especially intraoperatively. And once you do a general hydrodissection, don't do multiple, just a general dissection. And again, you decompress the anterior chamber, decompress your back. Then you just use a routine stop and chop on whatever it is, chop on. Only thing is you take the multiple pieces of the nucleus of recommendation, because if you do multiple pieces, the less chances of causing damage to endothelium. If you do only 2, 3, and you try to eat because the chamber is very narrow. So it's better to make to multiple to 8 to 10 pieces of this nucleus. Then you can emulsify, and the parameter setting is low parameter. See, my vacuum is only around 1, it doesn't go more than 200. So leave the low parameter vacuum, lower aspiration rate. Then you finish your phaco. One more thing is, once you finish the phaco, the subincisional cortex is sometimes difficult to take it out. So don't hesitate to use bimanual IA to remove your, especially your subincisional cortex. So because that will be very easy, otherwise you'll be struggling to do. And also, next thing is better to use a 3-piece in the intraocular lenses, because the 3-piece have better stability of your lenses. Because use a single piece, then the whole lens will be pushed anteriorly, then you will not be able to form the AC. So better to use a 3-piece. So you can also do an either sulcus or you can use a fixation in the back. So once you dial into the back, then you are more or less safe. And one more thing, you try to remove the visco under the IOL. Normally we don't remove under the IOL, but to remove under the IOL, see the rexus margin is vertically oval. It typically shows at the end of the surgery. Also try to close the wound. Again, very important to close the wound at the end of the surgery. So this is the pre-op and post-op. AC is formed and a little bit of FM is there. And the intraocular pressure 1 month is around 16 and the vision is improved to 6/12 of this case. This is again an intraocular malignant glaucoma because this is a surgery done by one of my fellow and then they called me for high pressure. And then I just went there, I removed this, I put the nucleus back to the patellar fossa because he done a multiple hydrodissection and the nucleus is pushed forward. So because of that, I told to shift case to my table. We just waited for give mannitol. Then he proceeded with a phaco. This is a slow setting. This way, this is if we do multiple hydrodissection, especially in a narrow angle, you can have an intraocular malignant glaucoma. You have to be careful. Then you do a slow setting. Then do multiple pieces of again phaco emulsification. Then you can safely finish the cases. Again, use at the end of the surgery. Better to. You saw the initial stages that the iris was floppy, and when I push, always better to feel the eye whenever you're doing phaco because sometimes it will be very hard, then you cannot proceed. If the eye is softer, then you can proceed. Okay, again use a bimanual to remove your subincisional cortex. Then you at the end of the surgery, you need better to suture the wound. This kind of cases need to suture the wound. If you don't suture, the high chances of see the floppy of the iris. It's better to suture the wound so that you don't have any post-op complication. So I think the challenge is especially in this case of the shallow antechamber, decreased endothelial cell count, thick lens, poor dilatation, floppy iris, posterior sinus K, high IOP, weak zonules. These are multiple component, and I think it is breaking the sinus K using high viscosity agents and intracameral adrenaline also can be used. Sometimes be careful to use adrenaline because of endothelial cell count can come down with this also preservative of adrenaline. So better to aspirate the lower rate and lower vacuum and use a better viscoelastic, and better to remove this viscoelastic under the IOL just before you come out. And intraocular pressure IOP is common, especially in the complication, and DM detachment is also common. Into the cell loss is also 5%, and we may need for PKP. So 7 points I say is do a pre-op assessment, especially give diamonds of auricular cell pre-op. Intra-op assessment is very important. Feel the eye. That's very important. My boss has taught me. Whenever somebody has a difficulty, feel the eye. If the eye is soft, you proceed. If the eye is hard, close the eye, do next day. So intraoperative mannitol is important, and forming the anterior chamber, especially past release, pupillary membrane removal, and use of high viscosity sodium hyaluronate, pupil dilator, endothelial protection with visco, slow phaco, remove visco from under the IOL, and suture the wound at the end of the surgery is very important. Thank you.
Thank you, sir, for sharing those videos and giving us wonderful pointers. If doing phaco in angle closure disease is difficult, phaco trab is yet another ball game. So we have Dr. R. Ramakrishnan, my chief and my mentor, for talking about the phacotrabeculectomy in angle closure disease. Let's hear us from the stalwart, Professor Dr. Ramakrishnan, sir. For want of time, we'll take questions in the end if possible. So we'll go on to the next talk.
Good morning, everybody. At the outset, I would like to thank AIOS and the local organizing committee for